Good evening, my dear students. So, dear foreign medical graduates, I am Dr. Darwin here, and today we are here to revise ENT. So, without wasting any time, each and every second here is important, and whatever I would be teaching you today, each and every slide, each and every word is important. Please don't miss. So, I expect either as image based question, either as one liner, clear, or a clinical situation based upon these clinical images. So dear students, let's start. Now, before going to these slides, just have a look that this revision program is not a replacement for a regular course. So please be careful. This is just a supplement. This is just an add-on, right? And it includes all previous year questions, all recent advances, all clinical scenarios, and these are time effective notes. Within 1 hour you are going to take away so many questions, and it includes so many one-liners also. So dear students, keep focused about this preparation protocol. So let's start. Coming on, we will start with ear, then nose, then throat. So coming on to first important image. This is a site for preauricular sinus. Preauricular sinus. So somebody can ask you, what is a treatment of preauricular sinus? So treatment is excision. Now the problem is, many times you say excision, but excision is incomplete till you remove that wedge of cartilage where it goes. So suppose it goes like this, you have to remove this wedge of cartilage also. So excision plus this wedge of cartilage is important. Right question, important. Second important thing is, type 1 bronchial anomaly. So in type 1 bronchial anomaly, which is known as coloral fistula, type 1 bronchial anomaly. So here, if you see, internal opening is at floor of external auditory canal, and outside opening is in between angle of mandible and mastoid tip. So this is very important. You can see this track. So this is how you track it. Clear? This is known as coloral fistula. One opening at floor of external auditory canal. Second opening between mastoid tip plus angle of mandible. So this is important, dear students. Clear? And treatment, whenever you have to excise it, always follow parotid approach. That means transparotid. So whenever you need to operate, go through transparotid. That means which nerve is important in parotid? Facial nerve. So these are important questions. Clear? So we cannot go into details, you all know. I think you will cooperate with me, but yes, these questions are important in these 2 slides. Coming on to next. Students, what is this? What is in front of you? So in front of you, this is nothing but anosia. That means absence of ear. Dear students, if you have any question, please let me know in live chat. Clear? So I am seeing, don't worry. So this is anosia, that means complete absence of ear. So this question can be asked, that what is the age at which you repair this anosia or microtia when you have small dysplastic ear. So age is once this child attain age of 6 to 7 years. Why? Because either we take rib cartilage, clear, or suppose we take cartilage from septum, septal cartilage, or we take iliac crest. So all these are important sites from where we take cartilage to prepare this artificial, a sort of new pinna. So this question can be asked from you. Rib is a preferred. Clear? So anosia repair at 6 to 7 years of age. We prefer rib cartilage. Right, students? Next important slide. This is picture of absolutely normal tympanic membrane. You can see normal tympanic membrane and this peripheral thickened portion of a tympanic membrane. I hope you are able to see peripheral thickened portion of a tympanic membrane, which is known as fibrous annulus. So peripheral thickened portion is known as fibrous annulus. You can see, and this is dehiscent in attic. So in attic there is no fibrous annulus, and this is a region, this is known as unsafe CUS1. So this is attic and this is known as unsafe chronic suppurative otitis media. Students, understood? If you have any problem, please let me know. So these are important representative questions which can be asked from you. So this is the reason I am telling you all these images and important statements. Now next is laryngosclerosis. So what is this laryngosclerosis? You can see by name you are able to analyze thickening of tympanic membrane. So what is it? It is collagen. That means in biochemistry you must have read mucopolysaccharide. So this is this deposition, that is collagen deposition or mucopolysaccharide deposition. If you have normal tympanic membrane, normal means just laryngosclerosis is there, no perforation is there, don't do anything, no intervention is needed. Clear? So this is important. Normal tympanic membrane, don't do anything. But yes, if you have hole, then you repair. So that is important. So this is about laryngosclerosis. You can be given image based question. What is treatment needed in this particular condition? So somebody may ask tympanoplasty, laryngoplasty, no active intervention. So in this particular case, no active intervention because TM is normal. So no active intervention, right? So this is laryngosclerosis. Then coming on to, you can see in this particular picture, what is your interpretation? You are able to see a small perforation. So this is nothing but chronic suppurative otitis media. So can you tell me what is treatment of this particular condition? What is treatment? So treatment here is laryngoplasty. So important thing, laryngoplasty is a treatment of choice. If you have to see ossicles also, if you have to remove middle ear disease also, then always go for tympanoplasty. So tympanoplasty is a broad term, but here you can see this is malleus. You can see malleus is normal. Clear? So inner ossicles, if you are able to visualize, that is also normal, go for laryngoplasty, simple surgery, right? So this is chronic suppurative otitis media. Dear students, I expect this question in your exams. That means there is a very high probability that you must be getting an endoscopic picture of middle ear. Very, very important question. Clear? Don't miss this important slide. In fact, in first chapter, this is the most important slide for you. So somebody may ask you, what is this? So quickly, I'll tell you structures. This is handle of malleus. This is incus. This is stapes. You can see stapes head. This is perforated tympanic membrane. You can see margins of perforation. I hope everybody is able to see. Clear? What is this? This is oval window because stapes articulates with oval window. So this is oval window. What is it? Few millimeters below oval window you have round window niche. So here any image based question can be asked. Examiner can point out at this region, examiner can point out at this region, anything can be asked. So you should be familiar. Whereas what is this? This is promontory. P for promontory. You can see. So what is promontory? It is medial wall of a middle ear. So please spend some time in reading this particular picture. I repeat, handle of malleus, incus, stapes, P for promontory. Promontory is very important. Bulge of a promontory is found by basal turn of cochlea. Clear? So basal turn of cochlea. And this is 9th or 10th nerve, Jacobson's nerve. Arnold's nerve, you can see Arnold's nerve always runs over promontory. So very important slide, middle ear anatomy. And if you take a deeper picture here inside, you know, very important structures goes like this. Can you see? So what is it? So this is nothing but facial nerve. So somebody may ask you this structure, and you can see in this particular picture that facial nerve is posterior superior to this oval window. This is oval window, this is round window. So this is posterior superior, this is posterior side, this is anterior side, this is superior, this is inferior. So very important picture, and this is the reason I am telling you that these structures are important. So this is a picture of ossicles, very simple. This is just to revise you that this is body of incus, this is lenticular process of incus, and I think everybody knows that lenticular process of incus is first ossicle to be necrosed. Clear? So this is first ossicle to be necrosed, this portion. Clear? So this is saddle joint, saddle joint. This is ball and socket. By shape you are able to analyze. So important question. So this is just a revision of that particular slide which I have shown you. You can see all structures in front. Clear? So spend some time in reading middle ear endoscopic picture again and again. I am telling you, dear students, please don't miss it. Right? And please give me feedback also how this, if you have any difficulty. Okay, so now coming to after middle ear labyrinth. So what you are able to see in this particular picture is bony labyrinth. Now can you see this is cochlea? So this is cochlea. You can see basal turn. This is basal turn of cochlea. This is apex. And this is middle turn. So this is cochlea in which cochlear implant goes. This is stapes, you can see. So this is, and you know that stapes articulates with which window? Oval window. This is a round window. So from round window here cochlear implant would be going. So purpose of giving you this particular picture is where cochlear implant goes. So here cochlear implant goes. Important question. Through round window niche. Very important. Whereas somebody may give you this picture and can ask you, what is this semicircular canal? So can you tell me, students, can you tell me what is this semicircular canal? So remember, any canal which is posterior superior to oval window, it is a lateral semicircular canal. So this is lateral. So this is lateral semicircular canal, this is posterior, and that is superior. Clear? So these are important semicircular canals you can see and its orientation. See, our purpose is to ask you some clinical questions, some point of clinical relevance. Clear? And these are practical points. We want to see whether you are able to tell what is the orientation of lateral semicircular canal. Can you appreciate some middle ear structure? So this is how we ask you these questions. So please don't miss it. Okay? And if you have any difficulty, please go to our regular teaching which we have given in our app. Now coming on to next important thing. So you can see what we have done. We have straightened cochlea like this. And cochlea has got three important compartments here. So what is this? This is scala, vestibuli, clear, scala media, and this is scala tympani. So you can see, clear. So these are three compartments, and most important is, we will be able to see in next picture. So yes, what is this? So if I ask you what are important hair cells, is it outer or inner hair cells? So important thing is that inner hair cells are very important. If you have any damage to inner hair cells, your hearing goes. So remember it like this: outer hair cells is responsible for autoacoustic emissions. Autoacoustic emissions. Clear? Whereas important is inner hair cell. It is more, as it is not like this that outer hair cells are not important, they are also important, but yes, it is a duty of outer hair cells to protect inner hair cells. Clear? So O for autocaustic emission, O for outer hair cells. So this is a nerve supply of a pinna, very important for infiltration whenever we do these surgeries under local anesthesia. So you can see that pinna is divided into upper 2/3, lower 1/3. You can see that lateral surface on upper 2/3 is plied from auriculotemporal, whereas lower portion, if you see, both lateral and medial aspect is plied from greater auricular. I expect these questions in your exams. Why? Because this greater auricular nerve is cut in parotid surgery. So please write here parotid surgery. Parotid surgery. Right? Important question. Greater auricular nerve. So this is about pinna. Then nerve supply of external auditory canal. Yes, very important. So many questions in this particular slide. I expect this question in your exam. Why? What is the reason? You know, floor of external auditory canal by 10th nerve. That means whenever you do itching in floor of EAC, patient has got itching and cuff reflex. So remember it with cuff reflex. Clear? So 10th nerve, auriculotemporal anteriorly, then greater auricular nerve posteriorly you can see, and here 7th nerve is important. Why? Because there is a sign that whenever we have acoustic neuroma, posterior-superior sensations are lost over pinna. So it is due to Hitzel. So this is known as Hitzel-Berger sign. Very important. So this is seen in which tumor? Acoustic neuroma. So I hope it is a sort of revision for you. Clear? So please don't expect me to go into details. Clear? So my point is just to tell you what are important things or important questions. So I expect these questions. So now I have completed your first chapter and you have seen that I have told you two important questions. One is endoscopic picture of middle ear. Yes, number one. And number two, external auditory canal, neural or nerve supply. So this is important. Now coming on to embryology, you already know that pinna develops from 6 axons of hillock. Yes, 6 axons of hillock. Clear? You can see this model. So now coming to autocaustic emissions. I have already told you that O for autocaustic emissions and O for outer hair cells. So yes, autocaustic emissions are generated from outer hair cells and it is used for neonatal screening of hearing. Neonatal screening of hearing. Even this question can be asked in PSM. So it is important. Clear? If anybody asks you, how do you do neonatal screening? We do with this device, which is nothing but autoacoustic emission. Alright? And it has to be done. Yeah. So is it going fine? Anybody who can message me? Is it going fine? Now coming to BERA. So if you see BERA, BERA stands for brainstem evoked response audiometry. Brainstem evoked response audiometry. Now you can see that BERA is recorded with multiple surface electrodes like this. You can see in this particular picture. Somebody can ask you that how what is being done in the following picture. So this is Bera, and here you record brainstem activity for first 10 milliseconds. So next important question which is asked from you, first 10 milliseconds, right? Yes, this picture is very important. I expect these sort of questions in your exams. Somebody can give you this picture and can ask, what is this in this following picture? Or somebody can give you this picture giving you waveform are like this. That means isoelectric line at 90 decibel, at 80, at 70, at 60. That means what is a diagnosis when you have isoelectric line, no waveform generation? That means patient is profound deaf. That means what is a surgery which you do? You do cochlear implant. So question number 1, question number 2. This is how we ask you question. So can you identify 10 milliseconds here on x-axis and decibels on y-axis? So this is nothing but Bera, where we use click as a stimulus, right? So this is all about brainstem evoked response audiometry, dear students. Okay, now coming to pure tone audiograms. So I expect one question from pure tone audiograms also. So you should be able to make this interpretation. So whenever you see, you know this is normal hearing. Why this is normal hearing? Because all lines here are roaming around 0 to 20 decibels. That means ear-bone gap and hearing threshold. Remember, these are two important parameters by which you can tell hearing of a patient. So ear-bone gap here is 0 to 20 decibels, and hearing thresholds, that means minimum intensity at which patient is able to hear, that is also less than 20 decibels. So dear students, these are important points. So this is nothing but normal hearing. What about conductive hearing loss? You can see in this particular picture. So what parameters I told you? Two parameters. One is ear-bone gap. Clear? So here in this particular picture, can you see ear-bone gap? That is increase. That is increase. That means it is nothing but conductive hearing loss. Question. Expect this question. So very simple question. You should be knowing this concept. So dear students, if you don't know, please go to your regular lectures, and I'm sure that you would be able to understand it. Clear? Then what about sensorineural? So I expect another question here. Sensorineural, that means can you see ear-bone gap here is reduced, but can you see this dip? So whenever you see dip, that means falling audiogram. Remember, whenever you see any falling audiograms, that means it is nothing but sensorineural hearing loss. You can write in brackets falling audiogram. Sir has asked us, falling audiogram is suggestive of sensorineural hearing loss. So this is an indirect hint for you. And can you see this is at higher frequencies, 6 to 8 kilohertz. That means it is nothing but, somebody can ask you three important differentials of high frequency hearing loss. So they are presbyacusis, that means age related, ototoxicity, and you know that ototoxicity is very common in India, tubercular treatment, ototoxicity, and finally, you know, noise induced trauma. So these are three important reasons. Very important question. All right. So yes, so this is about sensorineural hearing loss. Any question, if you ask me, please let me know. Dear students, don't hesitate to ask questions. Okay. So now I would not be telling you about mixed hearing loss. Remember, we will not be asking you mixed hearing loss. We want that our students should be able to differentiate conductive and sensorineural. At this point of time, I will not confuse you. So now coming to tympanometry. Yes, this is also important, and how we would be asking you question from tympanometry. We will be giving you this tympanogram. So can you see? Suppose this is tympanogram. Now you can see in this first picture, tympanogram is roaming around 0 decibel here, from minus 200 decibel or minus 300 decibel to plus 300 decibel. Now can you see? So that means this is nothing but a absolutely normal tympanogram, which is A. Important question. Clear? Whereas if it goes on negative side like this may be B type, and B type is always seen in, or this may be B or this may be C, and this is seen in otitis media with diffusion. Dear students, clear? Otherwise, classically, if you ask me, suppose this picture is like this, B is generally like this variety, which is known as dome shaped. Clear? And C is classically this variety. But yes, you will not be wrong, because every otitis media has to be started with eustachian tube dysfunction. So C variety means eustachian tube dysfunction, B means otitis media with diffusion. So this is most important question B, which is known as flat or dome shaped. Right. So this is about tympanogram. See every word, friends. I have bought these slides after doing a lot of homework. So every word here is important. 226 hertz, decapascals, A type. So these are all questions which can be asked from you. So spend some time in reading all these important things. Now coming to malignant otitis externa. Yes, very important slide. You know, malignant otitis externa is basically disease of immunocompromised patients, just like we see mucormycosis nowadays in COVID period. So again, this condition is also seen in immunocompromised patients. So we have positive gallium scan, positive technetium scan. And which agent causes this disease? Pseudomonas. Clear? What do you see on otoscopy? Granulations. What is a hallmark feature? Severe otalgia. Plus many times in these patients you see facial nerve paralysis. So very important slide, you must be reading it. Clear? So dear students, am I audible? Say yes or no please. Okay. So malignant otitis externa. Now coming to acute suppurative otitis media. Okay, so yes, I am getting your responses. So good. So coming to acute suppurative otitis media. Now dear students, what you are able to see in this picture is, can you see? Can you appreciate some fluid inside middle ear? And in case of acute suppurative otitis media, in fact this picture would be slightly red, like this. So this is known as cartwheel sign. Cartwheel sign. Clear? I mean to say leash of blood vessels running in a radial direction. I am getting your response. Thank you so much, Ashish, Hazel. Very good. Anishka. Yes, Arya. So this is cartwheel sign you get in acute suppurative otitis media. And dear students, please don't confuse yourself in acute suppurative otitis media or in otitis media with diffusion in this particular condition. This is known as otitis media with diffusion. In both these conditions, decongestants are very important. Decongestants are very important. That means whenever you have this disease, at least put xylometazole in nasal drops, Otrivin. You see in ads also. So Otrivin is important. And in addition to this, obviously you take antibiotic and you take antihistaminics. So in serous otitis media, important thing is, can you see these air bubbles? Air bubbles. So important slide. So you can get this clinical picture. You can get this clinical scenario also. And this is the reason I am giving you all these images, so that they are retained in your brain. So this is about serous otitis media, air bubbles or sometimes air fluid level like this. So decongestants, important thing. Now what is this? Yes, I think everybody knows this is nothing but ventilation tube, which is known as grommet. So grommet is made up of Teflon. So this is grommet, this is ventilation tube. You must be able to identify it, and this is how we put it. Yes, very important slide again. I expect this slide because nowadays you use earphones. Clear? So many viral infections, COVID-19. So this condition is precipitated nowadays, sudden sensorineural hearing loss. So dear students, whenever you have sudden sensorineural hearing loss, what is the definition? Definition is more than 30 decibel hearing loss, less than equal to 3 days. Clear? And more than equal to 3 consecutive frequencies. Clear? I repeat, more than equal to 30 decibel hearing loss, less than equal to 3 days, more than equal to 3 consecutive frequencies. Clear? 250 hertz, 500 hertz. So like this. So this is sudden sensorineural hearing loss. Treatment is obviously steroids, antivirals, vasodilators. And how do you give vasodilators? You apply transdermal patch of glyceryl trinitrate, carbogen, hyperbaric oxygen, which you also give in mucormycosis sometimes, hyperbaric oxygen under clinical trials. So this is treatment. So please spend some time in reading this slide also. I expect this question also. Yes, very important image based question, cholesteatoma. That means sometimes you get all these whitish flakes, large attic pocket. What is this? This is attic pocket. Can you see attic pocket? Any cholesteatoma, I will only give you single word. What is a treatment of choice? Treatment of choice is, dear students, only modified radical mastectomy, MRM. Clear? Safe CSOM, tympanoplasty, unsafe CSOM, MRM. Please don't confuse yourself. So modified radical mastectomy, which is also canal wall down mastectomy. I am giving you keywords only. This is the reason. At this point, no confusion, please. Clear? So canal wall down mastectomy, CWD, or modified radical mastectomy. Yes, these are important differences between safe and unsafe CSOM. I think everybody remembers these differences. Clear? So I will not waste your time. You can revise it. Clear? Yes. When to suspect complications of CSOM? So when you have high grade fever, when you have headache with vomiting. Clear? When you have massive ear discharge, or sometimes remember about your mind. Clear? So what happens whenever you have any brain abscess? What can happen? Headache, ataxia, visual alteration, seizure activity. So all these are important things. Clear? So somebody can give you some clinical situation here also. Good. So I am getting your comments. Thank you. So yes, important picture. What is this? Important post-auricular swelling. That means pinna is lateral and outward retracted like this. So that means yes, something wrong. Chronic suppurative otitis media, complication. And I expect this question in your exams, that these are 3 important abscesses which can be there. I repeat, Bizold abscess, Sitley's abscess, Lux abscess. Very, very important question. Even last year also this question was asked. Bizold, Sitley's and Lux. So what is Bizold? Bizold is beneath sternocleidomastoid. Clear? Whereas Sitley's is behind posterior belly of digastric. Remember, sometime I expect this question as an image based question. So please remember, if it is here Bizold, sternocleidomastoid, if it is behind digastric muscle here, then Sitley's abscess, and Lux is external auditory canal. Very, very important question. Yes. So Sagar, yes Sagar. Now petrositis. I think everybody remembers petrositis. It is known for Gradinego's syndrome. Clear? Gradinego's syndrome, which is characterized by 3D. Okay, very important question. That means diplopia. Clear? That means sixth nerve palsy, deep-seated ear pain, and discharge. So 3Ds. Petrositis 3Ds. Okay. Then brain abscess, you know, sigmoid sinus thrombosis. I think you must be knowing about sigmoid sinus thrombosis, picket fence fever. These are very funky words. So sometimes, by a single word, examiner asks you question. Grisinger sign is positive in, picket fence fever is seen in, Tobbe-Ayer test is done in, Crow-Back test is done in. So you must be remembering it. And in this CT scan, can you see what is this? This is delta sign. So what is delta sign? Can you appreciate contrast enhancement in vessel wall, but inside vessel everything is black like this. So everything is black here and surrounding is white. So this is seen in sigmoid sinus thrombosis. Sigmoid sinus thrombosis. Important, delta sign. Clear? I'm really sorry, my students, I am not going into detail, Clear? We want to revise here. So delta sign, sigmoid sinus thrombosis. Yes. What is the criteria for cochlear implantation? Criteria for cochlear implantation, this is, you see, FDA approved criteria, but wrong. So it is less than 5 years. So that means 6 months to 5 years of age group. 6 months to 5 years of age group. Severe to profound sensorineural hearing loss. So in fact, I would modify this slide. How I would modify this slide is 6 months to 5 years of age. Yes, this is one. And second is more than equal to 70 decibel sensorineural hearing loss bilateral. Dear students, only 2 lines about this cochlear implant. So this is criteria. I expect this question in your exams. Very important. So what is this? This is external portion of cochlear implant. This is transmitter, you can see T for transmitter. This is microphone plus speech processor. Clear? So these are external components of cochlear implant. Transmitter, speech processor, microphone. Clear? Whereas if you see internal portion, this is internal portion which is implanted inside. So this is a receiver stimulator unit, RS unit. And this is electrode array. Clear? So this is how cochlear implant looks. Don't do mistake. Clear? Sagar, I will be telling you Baha also, don't worry. So receiver stimulator unit, electrode array. And many times students, dear students, never answer question in 5 seconds. So see, this is cochlear implant, but this is auditory brainstem implant. So you can see this is plate of electrodes here, which is kept in lateral recess of fourth ventricle. Clear? And indication is neurofibromatosis 2. So very important. So this is auditory brainstem implant. Clear? And Sagar is asking, so this is Baha. So this is Baha. Baha means bone anchored hearing aid. You can see here, bone anchored hearing aid. Okay, clear? So Veer is asking me to zoom in. So can you see? Zoom in. Yes. So this is plate of electrodes. Clear? So yes. Okay. Yeah, Baha. Now this is your homework, that you have to read all these syndromes. Waardenburg syndrome, white forelock of hairs. This is homework for you. Clear? So nowadays, people are very fond of asking all these syndromes. Treacher-Collins syndrome, last year this question was asked, and I am teaching this question for last 10 years. Clear? So you can see Treacher-Collins syndrome. These patients, they have conductive hearing loss and they have ear anomalies. So this is the reason they have conductive hearing loss. So very important. Then coming to autosclerosis. I hope you know autosclerosis. Autospongiosis is always characterized by Short's sign. Clear? Short's sign. So you can see short sign is reddish pinkish hue over promontory. Clear? Over promontory. I am getting your questions, dear, so I would be answering it very soon. Don't worry. Clear? But due to lack of time, there are some restrictions. Don't worry, but I'll answer your questions. So you can see here, this is a PTA. So this is known for Carhart's notch. Carhart's notch. Clear? Autosclerosis is known for Carhart's notch. You can see dip at 2 kilohertz. Dip at 2 kilohertz. Whereas this is known as cookie bite curve. Cookie bite curve, which is seen in C for cookie bite, C for cochlear autosclerosis. Important, very important. Clear? Yes, Sagar, Carhart's notch. And this is Stapes piston. You can see. So this is Stapes piston. So you should be able to identify this thing in your exam. Okay, right? And somebody can ask you, in this picture, which of a following surgery is being done? So you can see piston winding around incus. This is incus. This is oval window. So that means someone is doing here Stapes surgery. Stapes surgery. So that means someone is attempting here Stapes surgery. So please don't do this mistake. So this is Stapes surgery. A very important question, can be asked as image base. Then temporal bone fractures. So remember, whenever we talk about temporal bone fracture, this fracture line is going parallel to longitudinal axis of petrous pyramid. So this is longitudinal fracture. So this is longitudinal fracture. Clear? Whereas if you see, this fracture line is going transverse to longitudinal axis of petrous pyramid. This is a region. This is known as transverse fracture. Clear? Simple diagnosis, simple question. Okay. Abhishek, stepidotomy. Yes, Abhishek, this is stepidotomy. Good, very good. Then Meniere's disease. I hope everybody of you knows about important symptoms of Meniere disease. That means more than equal to 20 minutes vertigo. Clear? Then you know tinnitus. Clear? Then you know sensorineural hearing loss. Please don't do this mistake that you say conductive hearing loss in Meniere's. No, it is sensorineural variety. Clear? So these are important features. And finally, there is ear fullness. Clear? I hope you remember that beta histine is a drug of choice. Beta histine is a drug of choice. Yes. So this is about Meniere's disease. This etiology, you know. I hope if you get this picture, if somebody asks you what is being done in the following picture, this is something which you do for benign proximal positional vertigo. So what is this maneuver? This maneuver is Apley's. Clear? To treat. So Apley's is very important. So you should know difference between Dix-Hallpike and Apley's. Clear? So don't do this mistake. So this is Apley's is treatment maneuver. Dix-Hallpike is diagnostic. D for Dix-Hallpike. D is diagnosis. Okay. So this is Apley's. Then superior semicircular canal dehiscence. Yes, these are important things. Hannibert sign, Tullio's phenomena, third window effect. I expect this question in your exams. Very important. Yes. Clear? Then this is something again very important, which is reddish mass behind intact tympanic membrane. So what is this? This is glomus, a reddish mass behind intact tympanic membrane. And you know, that these are important features: pulsatile tinnitus, hearing loss, oral fullness, brown equino sign. So these are important things. I hope everybody of you remembers about these important symptoms. Clear? So glomus means it fills middle ear cavity, so it is characterized by conductive hearing loss, right? And what is there in this picture? This is acoustic neuroma. You can get this MRI, acoustic neuroma, CP angle tumor. Can you see? CP angle tumor. Okay, this is petrous apex. So near this internal acoustic meatus you have this tumor, which is acoustic neuroma. Very important. Bell's palsy, you know, I am not spending time over it. Yes, and these are some dissection. Yes, Trotman's triangle. Trotman's triangle you should also remember as venous triangle. Okay, you remember it as venous triangle. So you can see, if you remember venous, then two boundaries you will automatically remember. One is sigmoid sinus, second is superior petrosal sinus, and third is bony labyrinth. You can see here semicircular canals. Clear? So like this you are able to remember. So this is Trotman's triangle. Important landmarks. Yes. So dear students, by this picture I want to show you how cholesteatoma flakes look like. So these are cholesteatoma flakes, keratin flakes. Clear? Somebody can ask you this clinical question, and I told you whenever you see this word cholesteatoma, that means you do which surgery? MRM, modified radical mastectomy. So this is all about ear, dear students. In next picture we have cleared this cholesteatoma flakes. Now we will proceed with nose and paranasal sinuses. Clear? Abhishek is asking ice cream cone appearance. So Abhishek, ice cream cone appearance we use for ossicles. Clear? Where we see this head of malleus like this and body of incus like this. Clear? So ice cream cone appearance. Good, very good. I am happy that you remember these words. Very good. So coming to nasal septum. Yes, nasal septum you are reading from your first year anatomy. Just to revise you, this is perpendicular plate of ethmoid. This is vomer. This is rostrum of sphenoid. 1, 2, 3. Somebody can give you this picture and here he can write X. What is X? Clear? So this sequence is again, these bones are again important, these portions. So don't come under examination stress. Just relax and you will be able to solve. These are very important, easy questions which you are reading from your first year. Yes, even last year this question was also asked, that which of a following vessel does not participate in Little's area? Posterior ethmoidal. Clear? So you can see how Little's area is formed. Clear? I will not go into details. You already know it. Posterior ethmoidal artery is the answer. Yes, this question is again important. So I expect this image based question, because nowadays we are doing so many septorhinoplasties or cosmetic surgeries. So this is ascending process of maxilla, important. This is upper lateral cartilage, important. This is lower lateral cartilage, important. Somebody can give you this picture and can ask you what is this. Clear? So you can see in this particular picture, spend some time at least after this presentation, that how upper lateral cartilage and lower lateral cartilage looks like. That is what we would be asking you. So purpose of putting this picture is just to tell you that CT scan is an investigation of choice in paranasal sinuses. Okay. Yes, this is a first step of FES, functional endoscopic sinus surgery. So what surgeon is doing here is, you can see he is cutting uncinate process. Uncinate process. So uncinectomy is a first procedure of FES. You can see it is being done with sickle knife. Sickle knife. Okay. Next important thing is, can you see examiner is giving you this hint that this is sphenoid sinus, this is sphenoid sinus. What is this cell which is lateral to sphenoid sinus? So answer here is Onodi cell. Clear? Onodi cell. So answer here is Onodi cell. I'm getting your questions. Don't worry, Sumed, Vicky. Clear? I think these answers you will be getting over app very soon. Don't worry. At present, I am focusing to complete my presentation. So don't worry. Bear with us. Okay. So this is sphenoid sinus. So this is Onodi cell. Important question. Which is lateral. O for Onodi. O for optic nerve. Clear? Optic nerve. So its relation is with optic nerve. So you can see Onodi cell in this particular picture also. Parnava, Jarjavi fracture. I would be telling you Parnava. Don't worry. So coming to Agar-Nezai cell. See, Agar-Nezai cell is described with relation to frontal sinus. So you just remember this single word, frontal sinus. So whenever you have to open this frontal sinus, can you see this Agar-Nezai cell? You have to open this cell first, and then you will be entering. So Agar-Nezai cell is anterior most ethmoidal cell. Anterior most ethmoidal cell. Clear? Okay, right? Then Haller cell. Yes, Haller cell is infraorbital. You can see here Haller cell. Haller cell is infraorbital cell, and can you see it is in maxillary sinus, M for maxillary sinus. So Haller cell is infraorbital. These cells are important. What is this? I think everybody has seen whenever you have gone to ENT OPDs. So it is, what is it? It is endoscope. These are nasal packs which is known as merocell. Okay, so yes, these are radiological pictures you must have seen. So this is a CT angio. This is CT angio picture. Your radiologist must be teaching these investigation to you, and this is digital subtraction angiogram. And can you see this tumor blush? Sorry, I'll use this marker. Yes, so can you see this tumor blush? So these investigations are very useful whenever you deal with some vascular tumors. And you know, can you name one vascular tumor in nose? This is nothing but juvenile nasopharyngeal angiofibroma, right? GNA. Then coming to CSF rhinorrhea, can you tell me most important site for CSF leak? Cribriform plate. Yes, very good. Then frontal sinus, posterior wall. And finally sphenoid sinus, lateral wall. So this is about CSF rhinorrhea. Yes, dear students, I expect this question in your exams. Kiros classification. So you can see Kiros classification is used for depth of olfactory fossa, like this. So in first, less depth, in type 2 more depth, type 3 more depth. You just remember it is for depth of olfactory fossa. So this is for you. Yes, Ashish, Abhishek, very good. I am getting your answers. Good. HRCT investigation of choice. You people are so intelligent, I am telling you. Clear? So very good. It motivates me also. Clear? So I always learn by teaching. So what is this investigation? Can you see? This investigation is yes, MR cysternography. So can you see this shining? This is orbit. This is O for orbit. Can you see this shining structure inside nasal cavity? So this is nothing but meningocele. Clear? That means CSF. This is CSF containing sac. So MR cysternography, remember, this is very useful investigation. in case of CSF rhinorrhea. And let me revise you, these are important signs: halo sign, reservoir sign, handkerchief sign. So these are important signs in CSF rhinorrhea. So I'm getting some personal questions, so don't worry students, no personal question at present. Let me focus on my presentation. So CT or MRI cysternography, yes, these are important investigation and you can see in front of you. So remember, both investigations are complementary to each other. This is the reason I have put this slide, CT and MRI. Clear? So CT is for bone, MRI is for CSF leak. Clear? To see CSF. So please read this slide. Yes, what is Hebra nose? Hebra nose is rhinoscleroma. Rhinoscleroma. Somebody may ask you, rhinosporidiosis. You know that rhinosporidiosis is known for massive epistaxis. So sometimes somebody may give you that very notorious statement, working in rice paddy field, Andhra Pradesh, Bihar, ponds water, and I am 100% sure that you will be able to solve this question. Rhinopyoma, potato tumor, you also know it. Clear? So what do? You fulgurate it with laser. Clear? You fulgurate it with laser, slow sittings, or you can just excise it and apply split skin graft, but that is not advisable. So use laser. We have laser nowadays, and preferred laser is CO2 laser. Clear? Where wavelength is 10,600 nanometers. This is not millimeters, this is not kilometers, this is nanometers. Clear? So these are nasal polyps, pale grape like structures. Yes, I expect these questions in your exam. Clear? Carter-Jenner syndrome, Young syndrome. So please remember these syndromes. This is important. Samter's triad, yes. Clear? I have recently seen this question being asked last year. Then enteroconal polyp is also known as Killian's polyp. I think every student remembers it. And treatment of choice. Whenever you are not able to tell anything in rhinology or nose, remember FES is a treatment of choice. You will be 99% right. Clear? Functional endoscopic sinus surgery. So these are steps of FES. This is for you. So please remember it. First step is uncinate process removal. Yes. Okay. Yes, inverted papilloma is very important, which is known by so many synonyms. Schnitzlerian papilloma, Ringer's tumor. Clear? And here again, treatment of choice is, you have to remove this maxilla medial portion. So that means medial maxillectomy is a treatment of choice. And everything is endoscopic. Clear? Everything is endoscopic. Thank you Ashish, thank you Abhishek. So FES, Zeba, yes, FES is a treatment of choice. Clear? So indirectly when we talk about endoscopic medial maxillectomy, that means endoscopic medial maxillectomy is nothing but endoscopic surgery. Clear? So by saying endoscopic surgery, you are not wrong, let me tell you. Yeah, these are two important questions, that Orngrens line or Orngrens classification is meant for paranasal sinus malignancies. You remember this Orngrens line like this. Can you see? From medial canthus of eye till angle of mandible. So suprastructure, infrastructure, and just a slight modification of it is Lederman's classification. Clear? So this is Orngrens and Lederman classification. These x-rays you know. I expect one question on x-ray also. This is very easy, but don't do mistakes. So either Waters view, which is for maxillary sinus. Clear? Or Caldwell view. Clear? Which is for frontal sinus. So you can see here excellent delineation of this frontal sinus. So it is nothing but Caldwell. And here you can see excellent view of maxillary sinus. So it is nothing but waters. Okay. So yes, what is this? This is Pott's puffy tumor. Sometimes you get this interesting question, Pott's puffy tumor, which is nothing but a complication of a frontal sinusitis. Okay. Remember students, I expect this question of fungal sinusitis in your exams. Very, very important. And I think details of this fungal sinusitis you can also see in our YouTube video, where we have given you very precise and crisp description. Clear? So I always believe that presentation should be crisp. So yes, this is a classical hallmark feature of mucor. I repeat, mucor hyphae are aseptate, right angle branching. Clear? You remember these keywords. Whereas aspergillus, you know, they are oblique, acute angle branching, and second is they are septate hyphae. So this is about fungal sinusitis also, and these are areas of hyperattenuation which are classically seen in AFRS. Clear? So all these videos we have uploaded in YouTube also, so you can see these videos. Clear? In app also. So now coming to juvenile nasopharyngeal angiofibroma. So if you ask me juvenile nasopharyngeal angiofibroma, yes, this is important question. If you see, so what is this? This is known as Holman-Miller sign. So can you see anterior bowing of posterolateral wall of maxilla like this? So this is Holman-Miller sign. Important. Sagar is asking septate hyphae. Septate hyphae, Sagar, septate hyphae is seen in aspergillus, not mucor. Clear? So I expect this question because you know this epidemic has occurred recently. So Mithyam Midhu, yes, there is a physiology class after this class, so let me finish it and then you have physio class. So nasopharyngeal angiofibroma, yes, treatment of nasopharyngeal angiofibroma is chemoradiation. I repeat, chemoradiation, and all these are important etiological factors. Remember here in nasopharyngeal carcinoma, etiology is Epstein-Barr virus. Clear? I repeat, Epstein-Barr virus, not human papilloma virus. This is a common mistake and this question has been asked 2-3 times. Clear? So this is important. This is microdebrider which we use to do FES, and this is coblation. Clear? So yes, somebody was asking me Jarjaway fracture. So Jarjaway fracture is when fracture starts from front, clear, and runs horizontally. When there is a blow from the front end, it runs horizontally backwards like this. Clear? So this is Jarjaway fracture, and Chevalier fracture is when there is a blow from below. Clear? Like this. So whenever you have time, please remember this maxillofacial trauma. One question would be asked from maxillofacial trauma. Clear? So I have given you these nasal fracture, zygomatic fracture, yes, you can see. Clear? And you can easily remember this is zygoma, so you can easily remember. You will have ecchymosis also, you will have depressed cheek also. So think logically and you will be able to enumerate every feature I am telling you. So important. Clear? Yes, this is very, very important, these fracture line. So this slide is very important. You can see here, this is known as transverse fracture, transverse. This is known as pyramidal fracture, and this is known as craniofacial disjunction. So spend some time in reading Leaford fracture. I expect this question in your exams, very important. Clear? So this is end of our rhinology also. This is blowout fracture of orbit. You can see this question was asked, I think, last year. Blowout fracture of orbit. Clear? Important. So now coming to this oral cavity and pharynx. I will be taking 20 minutes more. Clear? So please, I will be able to finish at 8:30. Don't worry. So this is leukoplakia, this is ranula. You can see bluish translucent swelling in floor of mouth, ranula. And remember, for ranula, treatment of choice is not marsupialization. It is always excision. Clear? It is always excision. Let me tell you. So this is leukoplakia, whitish plaque. So leukoplakia should be either observe or subject them to biopsy if you suspect malignancy. Clear? So this is tonsil, you can see, and tonsillectomy nowadays, you know, we use so many gadgets here, and in this particular thing we are using coblation. Clear? So coblation, laser. Okay, so these are important. Abhishek, teardrop sign. Yes, Abhishek, teardrop sign is seen in blowout fracture of orbit. Clear? So orbit goes like this. So teardrop sign. So what is this? This is tonsillar sneer. Very good. It seems you people are well read, and this is, I'm really very happy, to be very frank, that you are very well read. You know each and everything. Good, very good. So tonsillar hemorrhage. You see these are various types of tonsillar hemorrhage: primary hemorrhage, reactionary hemorrhage, secondary. Just want to tell you that important source of tonsillar bleed is always vein, not artery. Clear? So this is indirect laryngoscopic mirror, IL mirror, whereas this is posterior rhinoscopic mirror because it has a bend. So you can see these mirrors. Yes. Then this is adenoidectomy being done, and this is tonsillar sneer. Coming on to Grisel syndrome, you know, this is a very important complication of adenoidectomy, particularly when we do conventional varieties like this curettage method. So this is nothing but atlantoaxial subluxation. So Vicky is asking me Quincy. So Vicky, Quincy has come. So this is peritonsillar abscess. You can see these. Most of a time, I am telling you, 99% question would be within this slide only. So you can see Quincy is always a complication of unilateral tonsillitis. So uvula will be pushed to opposite side. So this is how you can see hot potato eyes, halitosis, trismus. Clear? So important thing. And this is Ludwig's angina. So whenever the dictum is, whenever you have any abscess, just drain it. That means incision and drainage. Clear? So this is again important. And similarly, parapharyngeal abscess, you can see this huge parapharyngeal abscess. Again drain it. Clear? IND. Whereas, okay, so I'm getting your questions, don't worry. So now what is this? You can see posterior pharyngeal wall swelling here, which contains pus. So this is nothing but retropharyngeal abscess. And remember, dear students, many of your old books has written incision and drainage and retropharyngeal abscess. No, don't go for IND in retropharyngeal abscess. Here you can do needle aspiration. Needle aspiration. Clear? So wide bore needle aspiration, because bleeding would be less. So this is a classical x-ray which you get in retropharyngeal abscess. I hope you must have got this x-ray. That means straightening of a cervical spine, increase width of prevertebral shadow. So these are important things in retropharyngeal abscess. Yes, I expect this question. So yes, this is a foreign body. You can see quine. But purpose of putting this x-ray is that whenever you are able to see double ring sign like this, then that is not a quine, that is a cell battery. So don't make this mistake. Double ring sign is always seen in cell battery. So this is indirect. Now we are moving to larynx. You can see this endoscopic picture. These are important differences of adult and pediatric larynx. Yes, narrowest portion is subglottis, whereas in adults narrowest portion is at a level of vocal cords. I expect this question in your exams, laryngeal muscles. And when we talk about laryngeal muscles, only two important muscles. What is this? Posterior cricoarytenoid muscle and second muscle I'll tell you. So posterior cricoarytenoid is abductor of a cord, very important. Whereas if I talk about cricothyroid is a tensor of a cord. Clear? Cricothyroid is a tensor of a cord. So you can write here cricothyroid. Where cricothyroid has gone? Yes, this is a cricothyroid. This is a tensor of a cord. So these are two important questions. Very high probability of asking this question. Simple question. Clear? So then Rinke's space. Yes, whenever you have a Rinke's space edema, this is known as smoker's larynx. Very important, smoker's larynx. So somebody can ask you this synonym, and this is very common in patients, those who smoke, those who do vocal abuse. Clear? Treatment is nothing. Whenever you are not able to tell anything in larynx or vocal fold disorder, you always tell no coffee, no tea, no spicy food, and no gastroesophageal reflux. Clear? So yeah, recurrent laryngeal nerve. So you can see here that left recurrent laryngeal nerve is always lower in onset. Very important. So you can see here that left recurrent laryngeal nerve winds around arch of aorta, whereas right recurrent laryngeal nerve winds subclavian artery. So this is important. Okay. So one question would definitely be asked regarding all these cranial nerve these vocal cord paralysis. So like in this picture you can see one cord is lateralized. Can you see? So this is unilateral cord palsy. Whereas can you see this is bilateral abductor cord paralysis. So whenever you have bilateral abductor cord paralysis, you want to increase this space. So you take out this chunk of tissue, and this surgery is known as Kashima's operation. Kashima's operation, very important. Clear? So bilateral abductor cord paralysis. Yes. Clear? So this is Kashima's operation. Students, can you see this more space? And this question was asked, I think, last year. Kashima's operation. So all these are very important questions of great clinical relevance, because nowadays we see so many cord palsies, unilateral, bilateral. Clear? So this is Kashima operation, you can see. Yes. What is the treatment of this particular condition? Can you tell me diagnosis of this condition? This is nothing but vocal polyp. So any vocal polyp should be subjected to surgical excision, that means microlaryngeal surgery. Abhishek Nath, chordoplasty. Remember Abhishek, there is no term known as chordoplasty. Clear? Woodman's procedure. We don't do Woodman's procedure, Abhishek. Clear? So that means you have read some old book. So don't worry. You just focus on this. Vocal polyp means MLS, microlaryngeal surgery. Okay. Whereas these are vocal nodules. Vocal nodules should never be operated. No surgery. Never do surgery. Always do speech therapy. And vocal nodules are bilateral. So yes, this is very important slide. Somebody can ask you, and particularly this medialization thyroplasty is important. Clear? And how this question would be asked from you like this. So which of the following thyroplasty is being done in this following picture? So can you see implant being put and cord is pushed medially? So this is type 1. Very important question. I expect this question in your exams because these phonosurgeries are very important nowadays. Good. Zaiba, video word, no surgery, good. So coming on to high tracheostomy. So high tracheostomy you always do in CA larynx. So many questions this question have been asked. So high tracheostomy carcinoma larynx. This is Rinke's edema. I have already told you smoker's larynx. And in puberphonia you do Gutzman pressure test. So remember, in puberphonia you press thyroid prominence backward and downwards and see thyroid prominence. So can you see voice change? So this is an important test, that if by pressing this thyroid prominence backward and downwards, if there is a significant voice improvement, that means yes, this is a low voice pitch. Clear? So this is a high voice pitch which has to be converted to. So this is a diagnostic test for puberphonia, Gutzman pressure test. Treatment is speech therapy. Remember, in spasmodic dysphonia, adductor spasmodic dysphonia is more common, that means adductor. And this question can be asked from you, that in spasmodic dysphonia, what is the treatment of choice? Botox, botulinum toxin. This question can again be asked from you, botulinum toxin. Clear? So yes, Abhishek, agree. So what is this in this condition? You can see this picture can be asked as an image based question. You can see ulceroproliferative mass with whitish patches of keratosis, nothing but CA larynx, carcinoma larynx. Important. Clear? And remember, dear students, please spend some time in reading this TNM staging. I expect this question in your exams. I cannot tell you here TNM staging, but very important is cord mobility. Clear? So we decide with cord mobility and thyroid cartilage erosion. So these two words are very important here. When thyroid cartilage is gone, T4 disease. When cord is fixed, T3 disease. Clear? So very important, and sometimes we ask this stage grouping. Clear? So sometimes I ask you this question, what is a stage of tumor? T1, N2, M0. And you can see that many times you guess, okay, T1, N2, let it be 2. No, it is not like this. It will come in directly T4 stage. So important question. This is nothing but electrolarynx. You can see, yes, last 5 minutes, friends. So electrolarynx, and this is tracheoesophageal prosthesis, TEP, which is very important modality for speech rehabilitation. Clear? So all these pictures can be asked from you, whether in clinical scenarios or whether they convert in image based questions. And this is how we put tracheoesophageal prosthesis. You can see. Okay. Yes, I think every students remember this particular picture. This question can be asked in pediatrics. It is nothing but omega shape epiglottis, which is laryngomalacia. Important. Clear? And in this second picture, can you see aryepiglottic folds has been released? Clear? So Gigi is asking, what about single nodule? So dear students, single nodule, we generally don't see single nodule. Clear? Nodules most of the time are bilateral. When somebody tells you about single nodule, that means he has to cross check his diagnosis, because most of the time this single nodule is not a nodule but a polyp. Clear? So this is about, now coming to respiratory papillomatosis. So respiratory papillomatosis, very important condition, notifiable disease by Government of India. Clear? So this question can be asked. I am directly coming to question, what is bevacizumab? Zaiba, I will answer you cold abscess, just wait. So bevacizumab, this is anti-VEGF, very important for papillomatosis. And second drug is cidofovir, which inhibits viral DNA polymerase. So very important drugs. Somebody can ask you this question. Then remember foreign bodies of larynx. So foreign bodies of larynx, you can see they can present with any feature out of these: croup, stridor, cough, dyspnea, aphonia. So these are important feature. And this question can again be asked from you, because we remove so many laryngeal foreign bodies, I am telling you. Okay. So yes, I have already answered this question. What is this nature of foreign body? So can you appreciate double ring sign? Double ring sign. So this is nothing but cell battery. Then coming to steeple sign. So you can see here steeple of a church. I hope you have come out with diagnosis. So it is nothing but acute laryngotracheobronchitis croup. Very important sign. It is like steeple of a church. Then thumb sign. Can you see this thumb sign? So thumb sign is seen in acute epiglottitis. Okay, acute epiglottitis. So at last we come out with tracheostomy. So you can see that high tracheostomy is done in carcinoma larynx. These are all functions of tracheostomy, alternate pathway for breathing. Clear? So one thing I want to tell you is that please remember complications of tracheostomy like subcutaneous emphysema, pneumothorax, tube obstruction. Clear? So that you will be easily able to read it. I know. Clear? Yes, I have bought you this slide of parotid because this is very important. In every year I see this question being asked. So remember, in parasympathetic supply, this ninth nerve is very important, and this is a reason that whenever we have Frey syndrome, we cut this nerve over promontory. That means glossopharyngeal nerve, that Jacobson's nerve. So very important, you please spend some time. And this is the reason that Frey syndrome is also known as auriculotemporal nerve syndrome. You can see. Clear? And all treatment modalities should be known to you. So these are all treatment modalities: anticholinergics, Botox injection, raising thick skin flap, okay, tympanic